We're going to wait another minute. We're going to, hello, everyone. Hello, everyone. It is my pleasure to welcome you to a community conversation around COVID and COVID vaccines. Today, we're going to focus on a very important topic, which is COVID in the setting of pregnancy and the safety of the vaccines and the latest recommendations and what we've learned about vaccines and pregnancy. We're also going to touch on some questions that a lot of you have had regarding fertility, reproduction. It's gonna be interesting and helpful, I think. My name is Santiago Neme. I'm an infectious disease physician here. I'm a clinical associate professor at the University of Washington, and I'm the medical director for UWMC Northwest. I'm honored to be partnering today with Dr. Alisa Cachiques, who is an obstetrics and gynecologist specialist at the University of Washington. She's an assistant professor within the Department of OB and is here to join the conversation and provide some expertise, particularly in terms of pregnancy and reproduction. Welcome, Alisa.
Thank you.
So I wanted to start by asking some of the questions that we normally hear folks wondering about. And I wanted to kind of start by asking you, what have you seen in terms of COVID and pregnancy since the beginning of the pandemic, and what you've been seeing, and what cases are you encountering, complications, et cetera?
Yeah, so this is a really great question. We have been, as all other services, seen a lot of COVID-19 in pregnancy. And I think at this point in the pandemic, from 2020 to 2021, there's really clear evidence right now that pregnant people who have severe COVID-19 illness do worse than people who are not pregnant. So that has to do with adverse outcomes specific to the COVID-19 illness. We know from multiple studies now that people with COVID-19 who are pregnant have a higher risk of being admitted to the hospital, being in the ICUs, needing that bypass treatment, the ECMO therapy, and even a higher risk of dying. So that is all evidence that's been coming out from now multiple studies. The other thing is that we also know in terms of perinatal outcomes, so that's specific outcomes to the pregnancy, that people who have had COVID-19 in pregnancy have a higher risk of having preeclampsia in pregnancy. And preeclampsia is that kind of condition where blood pressure goes up towards the end of pregnancy, and there's more protein in the urine, and it usually results in a need for delivery at some point during the pregnancy. There's also higher risk of preterm delivery and C-section. So this evidence is pretty clear. Now, I really think it's important to talk about this data in light of what we're seeing right now with the Delta variant. So data that we have from these studies is from this last year, so 2020, 2021, institutions like ours have been really busy in collaborating with multiple sites and collecting this data. But the data that we have right now on adverse events in pregnancy have to do with this, the wild type variant. That's not what we're seeing right now. We're seeing much more severe cases, and there have been discussions online with physician communities, and you can read stories online. But I just to give you an idea of what we're seeing here at the University of Washington, over the last 4 to 6 weeks, we've seen far more pregnant people with severe COVID-19 illness than we ever did in the peak of the pandemic in 2020 and 2021. And to put this further into perspective, at the University of Washington, we have one of the highest acuity levels within the country. So we treat the sickest of the sickest from the whole WWAMI region. But our pregnant patients right now with COVID-19 and pregnancy are the sickest of our patients as we have them in the hospital right now. And to give you even a further idea of who these people are, these are people who plan their pregnancy, they took their prenatal vitamins every day, they're watching, what they eat, and they contract COVID-19 illness and end up intubated in our ICUs. So we round on these patients. We've stood outside ICU doors watching the baby's heart tracings because the baby's deteriorating because the mom is so sick. We collaborate with our anesthesia colleagues and ICU teams to plan these emergency C-sections just in case the baby crashes or the mom crashes. We stand inside the ICU rooms while our pregnant patients are crashing and being intubated just in case there's need for an emergency C-section so that we can save one life, even if we can't save both. So these are really, really important things to realize when we're talking about the COVID-19 situation right now, as it is in not just University of Washington, but the major hospitals in Seattle and in the region and across the United States. We're just seeing much more severe COVID-19 illness. But data from this last year is very clear that COVID-19 illness in pregnancy does have a higher risk of resulting in adverse events.
Thank you so much. And Dr. Kachikis actually touched on a really interesting aspect of COVID, which is the Delta variant. As you guys know, back in in June, when a lot of the mandates around masking were lifted, we were actually evaluating data or scientific results of studies that were looking at the Alpha variant that was very similar to the ancestral or the initial, the wild type variant. And back then we knew that breakthrough infections, that is infections that happen after one is vaccinated, were very rare. We also knew that at the time, the ability to transmit the infection once vaccinated was actually extremely low and unlikely. And that led to a lot of the loosening of these restrictions. But then came Delta. And with Delta, what we've seen is that it's a much more transmissible virus. So we're talking that per case, per confirmed case, you're actually able to give COVID to 5 to 7 people, as opposed to the variant that we saw in March, which was 2 to 3 people. So that gives you an idea of how much more transmissible it is. There's also evidence that is more severe, particularly we've never seen so many children hospitalized, and we haven't seen the complications around pregnancy that Dr. Kachikis is actually talking about right now. So I think it's really important to highlight that. And when we talk about vaccines, we're also going to contrast what Delta really means in terms of the vaccine efficacy, and the vaccines still remained highly, highly effective. Thank you so much. Dr. Kachikis, do you recommend the COVID vaccine to all of your pregnant patients?
Yes, we do. So there are, historically speaking, the whole conundrum back in December was the fact that pregnant people and lactating people were excluded from the initial clinical trials for the COVID-19 vaccines. But since then, a number of studies have been published. We have the non-human data from each vaccine type that's offered in the United States. So for the Pfizer vaccine, Moderna, and Janssen, we have non-human data that did not show any safety concerns. But we also have now VAERS data, which is that vaccine adverse events reporting system that has not shown safety signals for pregnant and lactating people. There are studies from the CDC, one from April of 2021, looking at kind of like a quick glance at early pregnancy outcomes and not showing adverse events with the COVID-19 vaccine. There's a recent study that was published looking at miscarriage rates and did not demonstrate higher miscarriage rates from our baseline kind of miscarriage rate in the population. And then we've also published a study from UW here looking at short-term vaccine outcomes. So all the data that we have so far on the COVID-19 vaccine in pregnancy is very reassuring, and there are more studies to come, but we do recommend the COVID-19 vaccine in pregnancy, and that is also endorsed by pretty much all the organizations that represent OB providers in the United States across the board.
Excellent, thank you so much. Is there any subgroup of patients where you would not recommend the vaccine? I can't think of any myself, but is there any, other than someone younger than 12 years of age? I guess you can be younger than 12 and be pregnant. In that situation, it would be the only exception where I think one could based
Well,
on age, but
yeah, but that's based on clinical trials, right? So
exactly,
hopefully soon, 11-year-olds, hopefully not pregnant, but
exactly.
11-year-olds will be able to get the vaccine.
Yes.
The only group I can think of are people who have really had severe anaphylactic reactions with the vaccine. So any contraindication for the general population is really the only one that I can think of, and there really just aren't that many, because even, we recommend the vaccine specifically for immunocompromised and people who are at a high risk. So there are very few contraindications to getting the vaccine unless you have like a very, very severe anaphylactic reaction.
Yeah, in which case you can also seek consultation with an allergist, and we also have the ability to do that here at UW. But yeah, it's great to highlight that vaccination is recommended for everyone who meets the age criteria. Cancer patients, patients with autoimmune diseases, pregnant patients, diabetics, etc. All races, all ethnicities, all recommended. Excellent. What vaccines are approved for pregnancy?
In the United States, it's the three that are typically given to anyone. So the Pfizer vaccine, which now has full FDA approval, which is great. And then the Moderna vaccine and the Janssen vaccine all are fine in pregnancy.
Okay, excellent. I sometimes get the question around the timing. I run across some folks, some women who are pregnant, and they're basically like 1 month away from delivery, and they think, oh, do I want to wait? Should I just wait to complete that and not do it now? Or I'm like 2 weeks after I delivered, should I wait? What is your recommendation? Is there a time where the vaccine would be contraindicated?
No, not contraindicated. So I think of the COVID-19 vaccine a little bit the way I think of the influenza vaccine, which we recommend routinely in pregnancy, which is that we give the influenza vaccine in any trimester, any time, to help protect the pregnant person. And by protecting the pregnant person, we protect the placenta and the health of the placenta, the fetus, and then eventually the neonate. So anytime during pregnancy is totally fine. I would say that there's no time like the present to get started with the vaccine doses, because we know that it will take, aside from the Janssen vaccine, it will take 2 weeks after the second dose to really have that protective immunity. And so that's like at least 5 weeks out. In terms of people who are about to deliver, I would say, again, just go ahead and get vaccinated. There is some thought about, and there's some data, and we'll get more and more data on this, but the benefit of giving vaccines in pregnancy, one of the reasons we give the other vaccine routinely, another vaccine routinely in pregnancy, the Tdap vaccine, is to actually help prevent whooping cough illness in the neonate. So the placenta works really hard to push over those antibodies to the baby in utero, and helps protect the babies in those first few months of life when they really don't produce a lot of their own antibodies. There's also evidence about antibodies in breast milk if you choose to breastfeed your baby or feed your baby some of your own milk. So any time is good for the vaccine in pregnancy, because there may be some benefit to the baby and also to the baby through breast milk. And there are some preliminary studies showing presence of vaccine-generated antibodies in cord blood and also in breast milk. So that's all really exciting data.
That's really reassuring. A lot of the questions that we get right now, I think we live in an era of some misinformation, and there's a lot online around fertility. There are some women who have expressed that sometimes after the COVID vaccine, they've noticed some irregularities around their periods. I kind of wanted your opinion to see whether this is something, maybe we separate the topics. Let's first talk about fertility. Is there any evidence that the COVID vaccines affect your ability to have children?
No, there's no evidence to that effect. And I think what we've been seen, and there will be studies published on this too, but we've seen people get pregnant throughout their vaccine doses, even early on. A person who was pregnant with the first vaccine dose was pregnant with the second vaccine dose. So there's no evidence to show that there's any effect on fertility. Now, if you were a planner and you were planning to get pregnant and you had your calendar set, I would say get your vaccine before you try to conceive, because that would be, kind of like one checkpoint done. But as most people know, people tend to get pregnant when they're not planning it. So, anytime there is no evidence showing that there's decreased fertility with the COVID-19 vaccine.
Excellent. Is there any evidence or have you experienced that pregnant women who get the vaccine have kind of worse side effects or adverse reactions? How do they tolerate the vaccine compared to non-pregnant, from your experience?
Yeah, there are two studies kind of looking at short-term reactions. One of them is from our group here at University of Washington. These are, of course, self-reported data, both from the CDC and from our study. But pregnant people tend to do really well with the vaccine, possibly even potentially better than non-pregnant people. So what we do note is that, as with the general population, there are fewer short-term side effects with the first dose. And then with that booster dose, that really makes the immunity happen. There are some more side effects, but the side effects tend to be short-lived, so temporary and pretty mild. But pregnant people do really, really well with the COVID-19 vaccine.
Excellent. No, that's really important to highlight, especially, I would say, it feels like it's never been this important to get vaccinated, given what we're seeing in the country and the huge split between what's happening in the unvaccinated world versus the vaccinated world, right? Like currently at UW Medicine, we have a total of 100, close to 100 patients with COVID. And what we see is that the vast majority, greater than 90% of those patients, are unvaccinated. And a lot of people are really regretting not having had the vaccine. And we hope that with these forums and these conversations, more people decide to choose the vaccine. I think it's also relevant what you said, that if I get vaccinated and I'm breastfeeding, I'm also passing some of those antibodies to my baby, and therefore I'll make him or her or they more healthy and protected. Excellent. Now let's talk a little bit about have you noticed or have you heard that women are reporting differences in their periods around the vaccination? Is that something that's alarming? Is that something that worries you at all?
Not specifically. So I have heard anecdotal reports of that. I think there are questions floating around, and I think if you Google it, there are some news articles, but I think this has not been substantiated, and I think it would be really hard to study. I'm not super worried about it. I think, like anything else, it deserves some attention, and maybe there will be some research on that, but I wouldn't be too concerned about that right now.
Excellent. There's a question from the audience here. Should a vaccinated pregnant patient get a booster shot? If so, what is the timing?
For a booster shot for pregnant? Okay, this is a great question. Right now, it sounds like, I can just send this question right on back to you, but the CDC has recommended that immunocompromised people get the booster shot. And I think the way things are going, it's probably going to also at some point include, the general population, pregnant population. But I think the data for that is still outstanding from what I understand. I think I have a few thoughts about this. One is, we need to learn more about the booster and whether the booster is the third shot is actually going to protect us significantly from breakthrough infections. So that's one thing. The other thing, though, is that, boosters are not unknown to us in pregnancy. So we give that Tdap booster, and we give it specifically during a certain time point in pregnancy, the end of the second trimester to the third trimester. That is to boost antibodies so the baby gets more protection against whooping cough. So I think it's a possibility, and I think it probably is coming, but I think we still need to look at the evidence in the general population and then kind of think about that in pregnancy.
Yeah, absolutely. I completely agree. As you know, we have, for the audience, we have the additional doses can be in a way categorized in two categories for me. It's like one is the additional dose that immunocompromised patients have, because what's happening there is that I expected that the response of a patient who is immunocompromised is going to be less robust or less full than an individual who is immunocompetent. So for that patient, I give them an additional dose to kind of complete the vaccination schedule in a way. But folks who are immunocompetent, what we're seeing is that 6 months or 8 months into after the second dose, that the antibodies wane. But I want to remind the audience that there's a flaw in just looking at antibodies, because the T cell activity of your immune system is really key, and it's long lasting. So if we just measure antibodies, we're always going to be chasing this because antibodies wane. Now, antibodies are important in blocking new infections. So a booster, I think, probably will have an effect in preventing infections in general, whereas the T cell activity prevents you from the time you get infected, it prevents you from progressing, from getting worse and getting sicker. So this is why, although we are seeing breakthrough infections in the era of Delta, we are still seeing that the vaccines, all three vaccines, are highly efficacious, against severe disease, hospitalization, and death. And this is why it's so important. I know that it can get confusing, and people are like, well, why would I get vaccinated if I can still get the infection? True, you can get the infection, but you're not going to end up as a patient of Dr. Kachikis or me. Or if you are, you're not going to be sick enough. So that's a key point here to drive. Excellent. We have another one for a pregnant person.
And just to add to that, this is anecdotal, but from what I hear, all of the patients that we've been treating inpatient have been unvaccinated. So we'll have to look at some of our own data, but as far as I hear from all the providers who have done these kind of emergency C-sections and have been rounding, they're all unvaccinated.
Right. So that's even more compelling. For a pregnant person who has already had the first 2 doses of an mRNA vaccine, what is the best gestational age to get the booster? Yeah, the same question. I think we're going to hear more about the booster. It sounds like it might be 6 months after the second dose. Initially, we thought it was going to be 8 months, and now it's looking more like 6 months. But I think there's going to be more specific recommendations for pregnancy. Yeah.
And I think for pregnancy, in terms of timing, it's going to be, why are we getting this third dose or booster dose? So if it's being given for the health of the pregnant person, then it's going to be any time. And if we're giving it to specifically kind of boost antibodies for the neonate or the newborn baby, then that would be more like typically second trimester.
Perfect. And this is exactly, so the follow-up question, would it be smart to delay a couple of months until the third trimester so the antibody level will have waned less during delivery and during the breastfeeding?
Yeah, so we try to give, I mean, this is like a theoretical question, because again, we want to protect pregnant people from getting COVID-19 infection, because that's not good for the placenta. But again, if you were planning on doing it to boost antibodies for the neonate, then you would try to give it at least 4 weeks before delivery. And after 2 weeks, you would think that antibodies kind of peak. That's why we give the Tdap between 28 and 32 weeks in pregnancy, typically.
Perfect. Thank you. And then there's another question here. Please use the Q&A function for the questions, please. Are there any data on whether or not infants who were inoculated in utero are showing any adverse effects? What does that mean? Oh, so the patient who is pregnant, what happens to the baby? Is that the question, or?
Yeah, I think the question is about adverse pregnancy outcomes, it seems like. And I think the study that the CDC put out back in April in the New England Journal of Medicine looked at different adverse pregnancy events, so like preeclampsia, small gestational or small size for gestational age in the baby, et cetera. And they didn't find any higher risk of these adverse pregnancy events compared to the general population. But again, you have to remember that that all is very reassuring. Also, these people who got who were vaccinated in the first wave, so the healthcare workers primarily, et cetera, who were vaccinated back in December have been delivering and are delivering now. So we're going to get much more data in the future.
Excellent. And I think you've touched on this. Can you speak to the risk to newborns from mothers who have been vaccinated, who haven't been vaccinated? Have we seen newborns getting infected with adverse reactions?
So for COVID-19 infection and infancy, I think what we're seeing, and this is, I don't think there are a ton of published data or studies on this right now, but I think from news outlets, we're seeing that infants are being hospitalized with COVID-19 right now. Whereas back in the peak of COVID-19, we were not seeing that with infants, which is really interesting. In general, there was always this question about if a mom has COVID-19, do we separate the mom and the neonate, which is not something we do, but just thinking about the risk for the babies. But the babies did really well during the original surge of the pandemic, but now we're seeing that infants are hospitalized for COVID-19, and that compounded with other typical viral illness in infancy, like respiratory syncytial virus, which is going around again now that the mask mandate went down, now back up, but who knows. So I think that's why the children's hospitals are being slammed right now too, because COVID-19 is actually becoming an issue in childhood and infancy, and there are also these other typical childhood illnesses. The other thing to think about though too with the infants is just the birth experience and your early postpartum course with COVID-19. Having COVID-19 when you're about to deliver your baby is not ideal. It means that there, of course, are limited visitors in the hospital, but if your loved ones have COVID-19, they're not able to come into the hospital with you to give birth. So there's been a lot of FaceTiming happening. And then, the postpartum course is also more complicated and difficult. So I think, we want birth to be a joyful part of life, and it just becomes more complicated when there's actually active COVID-19 infection at the time.
Absolutely. Thank you so much. If I'm one of the questions, if I'm COVID positive and I just delivered a baby who is negative, can I breastfeed my baby?
Yes. So I think breastfeeding is fine. I would talk to your pediatric provider about that though too. I mean, wearing a mask, trying to protect the baby is really important, but we also recognize that, bonding with the baby and the benefits of breast milk are also really important. You could pump breast milk and then feed the baby separately. So there are different ways to go around it and try to protect the baby. So using those normal precautions like masking and trying to limit, too much touching of the baby would be important if you yourself have COVID-19 illness,
right? Just
to protect the baby.
Are you offering the vaccine upon discharge for those who just delivered? There is a system now. We've launched an inpatient screening for this that's pretty new. So I don't know if labor and delivery has already activated this piece of the protocol. I'm not sure.
It should be activated. I've talked to some of the nurses about it, but it sounds like it's a pretty straightforward process, especially if patients are interested in it to initiate. Otherwise, it's kind of the nurses screening to see who has and has not gotten the COVID-19 vaccine. But if you're interested in getting the COVID-19 vaccine, we can absolutely give it before discharge.
Excellent, thank you. If an individual who has not been vaccinated and has a history of blood clots, is there a thought about which vaccine would be safer?
So in pregnancy, if you have a history of blood clots, typically we put you on anticoagulation in general, but that's a totally different discussion to have. I think there's concern about the Johnson & Johnson or the Janssen vaccine because of blood clots. Now, the pathophysiology or how those blood clots and how they're made and why they occur is different than what we typically see in pregnancy. So I think the thought is from all, the big OB organizations, Society for Maternal Fetal Medicine, American College of Obstetricians and Gynecologists, that the Janssen vaccine would be safe in pregnancy. Now, if you've already had a blood clot, then I would say maybe use one of the other ones. So Pfizer, Moderna are also very safe. So I'd probably err on the side of that with the caveat that there's really no data on that. But if you have not had a blood clot in pregnancy, the Janssen vaccine is thought to be safe.
Right. Thank you so much. And then do you have a brief update on the hospitalized patients at Children's? What I can say, and Alyssa, you might know more, but what I know is that, back in April when we were surging last year, Children's only had 1 to 2 patients. And a few weeks ago when I checked with them, they had 9 patients in the hospital with COVID, which is pretty high. And nationwide, you see that the pediatric ICUs are filling up with kids. And again, that correlates with the levels of vaccination of their parents and adults, because until children can get a vaccine, children under the age of 12, that is the main protection, the best protection is to get vaccinated.
Right.
For the adults to do it.
Yeah, and I would say just thinking about the downstream effects of that, if the children's hospital ICUs are full, then we can't transfer from our neonatal ICU to the children's ICUs, which then affects our ability to take care of our normal, high patient acuity, preterm deliveries, babies that have anomalies. So just the downstream effects are also really important to think about. When we are full here, just because they're full, that becomes a problem for all sorts of pregnancy conditions.
Yeah, and we are seeing that even in non-pregnant patients, where if you have hospitals with 96 COVID patients, then you have states who are calling us, do you have a bed for this patient who doesn't have COVID but needs a bed, needs care, and we're seeing a lot of that. Fortunately, at King County, the numbers appear to be leveling off, but I think it's too soon. It's not the same in Washington State, especially Eastern Washington. The data is looking more alarming, and we're still, most of our hospitals are pretty full, so it's still concerning. But again, the key here is to really get vaccinated. I would say in a second, I would trade for someone unvaccinated to get vaccinated versus a vaccinated person getting a booster. I think that it really, I think the unvaccinated should really make that decision, because I think it's going to get very hard, and things are going to continue to get more difficult, especially with the emergence of variants. And I wanted to open up. I don't know if folks have, let's see, any more questions. Oh yeah. There's a comment, safety in lactation, and that's it. I don't have a question. I don't know what that might be referring to.
Well, our study that we just recently published looked at short-term reactions with lactating people, and it looked like people who were nursing their babies tolerated the vaccine really well. I don't think that most people in that study also chose not to interrupt breastfeeding with the vaccine, and only a very small percentage thought that they had a lower milk supply that was temporary. So overall, it looks like people who are nursing their babies do really well with the COVID-19 vaccine. And again, there's that thought of antibodies. I've had patients who have been feeding their toddlers some of their breast milk when they're breastfeeding another baby, just to see if those antibodies also are helpful.
Okay. Thank you. Are there any data on whether the spike proteins generated by a vaccinated mom crossed the placental barrier And if so, their effect on the baby in utero?
So there has been a study published looking at any kind of placental adverse events with the COVID-19 vaccine, and they did not find any differences in placental pathology with the COVID-19 vaccine. A similar study was done with the COVID-19 infection last year. In terms of in utero outcomes, we kind of talked about that prelim data just is reassuring, doesn't show any adverse outcomes such as a higher risk for babies not growing well, having fetal growth restriction, preterm delivery, et cetera. Whereas we do know that there are adverse events associated with COVID-19 infection and pregnancy, and that's even people who kind of get over the hump and then go on to be discharged from the hospital, which is a great thing, but that there's a higher risk for preeclampsia and preterm delivery, C-section in those patients. Now, spike protein antibodies, so the IgG, the mature form of the antibodies do cross over the placenta. We have a couple of studies around the country that have been published looking at that. And then there are more centers doing research on that, including the University of Washington, looking at the antibody transfer. But that does seem to occur, which is really reassuring because we hope that will help protect the baby after delivery. Excellent.
I know we have 5 more minutes. I kind of wanted to see whether you have any final thoughts or summaries, or maybe some advice for those who are pregnant and fearful, because pregnancy itself is new and it may cause some anxiety. You know, you're going to have a baby, and so I kind of wanted to hear how would you talk to this person who is still on the fence about this, around this critical intervention?
Right. So I think it's really natural to have questions about something that, is fairly new, although we do have, compared to some of the experimental COVID-19 treatments, we have a really good amount of safety data in the general population, and even more so, more and more now in the pregnant population about the COVID-19 vaccine. So it's normal to kind of ask questions and try to be as best informed as possible. But healthcare providers here at University of Washington and even other institutions are more than happy to try to, sit down with you and talk through questions that you have. But overall, it looks like the COVID-19 vaccine is safe. COVID-19 infection is not safe. We've had deliveries of, during pregnancy, we always talk about, what patients envision their birth to look like and what their birth plan is, and skin to skin, and photos, and that is not taking place with these women who have emergency C-sections because of COVID-19. And in the best case scenario, days after delivery, they find out that they delivered their baby. There's no skin to skin bonding. It's just a sad event for something that should be a joyful occasion. So we're happy to talk to you about the COVID-19 vaccine. It does seem very safe in pregnancy. There is thought that it could be beneficial for your baby. As you know, we don't have a vaccine right now for the infants. We don't have it for the pediatric population, but hopefully we will soon. So I think the clinical trials have gone all the way down to 6 months, but not beyond that. So I think it's going to be a while before we have vaccines for the very small babies. So we're really encouraging everyone to get the COVID-19 vaccine. That being said, at the University of Washington, we will not stop your care or refuse to see you because you haven't gotten the COVID-19 vaccine. We will talk to you about it though, but you can always still get prenatal care with us. There won't be any change in your care.
Excellent. Well, thank you so much. I really appreciate the discussion. Lots of great things to learn. We're going to be back on Friday to address additional questions that you've submitted. To the audience, please continue to send us questions because we're going to have Dr. Kachikas again next Friday to talk about this very important topic of pregnancy, fertility, and all the issues around COVID and how to keep everyone safe. Thank you so much for tuning in. I think Kelly will end the webinar. I think we can leave. I think she'll close up. Thank you, Lisa.
Thank you both. See ya.